We are live.
Okay. So good evening, postgraduates, and welcome to this 48th episode of All India Postgraduate Teaching Program, an initiative from Academic and Research Committee of All India Ophthalmological Society. We call this PG program with a difference because it covers the uncovered aspects of teaching programs which are not covered in other PG programs like the case presentations, the journal clubs, the OSCEs, and the didactics on topics which are not comprehensively available for you in a textbook at a go. So here we present our 48th episode of the series, and this is going to be a didactic lecture on newer glaucoma drug. This was a long question asked in one of the MS final exams. Today's didactic lecture would be presented by none other than a consultant from in glaucoma services from Arvind Eye Hospital, Dr. Prasanna Venkatraman. My special thanks also goes to Dr. Devang Angmo, who is an additional professor at RP Center, AIMS, New Delhi. Dr. Maitri Das, Senior Consultant, Glaucoma Consultant at Eye Foundation and Research Center, Kolkata. And also to Dr. Maya Maudawala, who is a consultant at Nucleus Eye and Skin Clinic, Mumbai. I'm really thankful to three of you for consenting to be a discussant. So now, without much ado, can I request Dr. Prasanna to share his screen and let us begin the proceedings?
Good evening, everyone. Thank you, AOS ARC, for the opportunity. Special thanks to Prashansa for the invite. So today's discussion will be newer anti-glaucoma drugs. So it will be actually not exactly anti-glaucoma. So we'll be dealing with drugs which reduce the eye pressure. So we have a long list of glaucoma drugs that we have since the beginning. So we have had pilocarpine, and then epinephrine, followed by timolol. But the breakthrough was in 1996 or 1987 when we had the introduction of prostaglandin analogs. So after that, we didn't have much of newer glaucoma drugs, which were really effective because PGAs changed the landscape of medical management of glaucoma. So only in 2014, from then we had the introduction of newer drugs like ROCK inhibitors. So these are the new drugs that we'll be discussing: Latanoprostene bunod, the combination of Netarsudil and Latanoprost, and the Netarsudil per se. But do we need new drugs? We all know there are so many glaucoma medications. So we have the standard beta blockers, alpha-2 agonists, carbonic anhydrase inhibitors, prostaglandin analogs. So we know prostaglandin analogs are the first choice drugs for controlling glaucoma medically, but these come with their own side effects, systemic as well as local. So if we can have some drug which has less systemic as well as local side effects, it is always good to start with. So we'll start with the ROCK inhibitors. So these are basically Rho kinase inhibitors. So why do we have the Rho inhibitors? So these enzymes, that is the Rho protein kinase, is located at the trabecular outflow pathway. So this basically promotes contraction of actomyosin, increases the cell stiffness, modulates cell adhesion, organizes extracellular matrix, regulates calcium independent smooth muscle contraction. So we have two enzymes, ROCK1 as well as ROCK2. So when we have these Ripasudil and Netarsudil, the ROCK inhibitors, this is basically inhibited. So all the downstream activities are blocked. So basically, ROCK promotes contraction and stiffness of the trabecular meshwork. So when we have inhibition of this ROCK, everything relaxes. So to understand better, this is the histochemical analysis of the trabecular meshwork pathway before ROCK and after ROCK. So you can see all these spaces thinning of the actomyosin complex. So basically, when we give ROCK, it causes relaxation of the trabecular meshwork and increases the outflow. So this is the molecule that we use, Ripasudil hydrochloride hydrate. So the concentration is 0.4%. We use it as a BD drug. So this basically causes dose and time-dependent reversible relaxation of the cytoskeleton of trabecular meshwork and Schlemm's canal. So basically increases the permeability of the Schlemm's canal endothelium, decreases production of the fibrotic extracellular matrix protein. So it inhibits both ROCK1 and ROCK2. So by inhibition of these enzymes, as discussed before, it improves the aqueous outflow by decreasing the outflow resistance. We all know in POAG or any glaucoma, the maximum resistance happens at the trabecular meshwork level. So this was the first ROCK inhibitor that was approved for use in glaucoma and ocular hypertension. So this was introduced in 2014 in Japan. So I'll not discuss much about the studies, but to give an idea about how these got into the clinical use. So this was a 1-year trial publishing the results of 0.4% Ripasudil in open angle glaucoma and ocular hypertension. So this was used as monotherapy as well as add-on with prostaglandin and beta blockers. So it had good IOP reduction. But what I want you to concentrate on is the side effect in the conjunctival hyperemia. So of the 354 patients who were enrolled in the trial, a whopping 74% had conjunctival hyperemia. So ROCK inhibitors are not without adverse effects. Conjunctival hyperemia and uh, microhemorrhages. So these are big side effects that we have to look into. So they did another post-marketing surveillance analysis. So we'll not go into the details of this study. So only to show, so previously we thought this ROCK inhibitors work only in open angle glaucoma. So, but if you see here, secondary glaucomas, primary angle closure glaucomas were also included in the trial. So in this study, as discussed, so majority of the patients had conjunctival hyperemia and about 30% discontinued the drug because of the side effect. So this is really significant. So, and they found this was really useful in all type of glaucomas except neovascular glaucoma. So we'll understand why this is really important when we have to know about the ROCK inhibitors. So Ripasudil is also used by the cornea colleagues. So Ripasudil, when used for cornea conditions, it is used in a concentration of 0.4%, but given 4 times a day. So why is the logic for the use in cornea conditions is in animal models, it is found to favor corneal wound healing. So whether it encourages migration and proliferation of endothelial cells is something we don't know. We don't have any concrete evidence for this, but it is being given a trial. So this study that we were discussing about the effects of Ripasudil had no cornea verticillata, no corneal edema, and bullous keratopathy. So, but this is not the real world scenario. This is what we see with the use of these ROCK inhibitors. So this is the classic side effect of the ROCK inhibitors. You can see this honeycomb or reticular edema. So this is classic. And one more thing is the profound conjunctival hyperemia. So as discussed in this trial, these drugs are not without side effects. So these really bother the patients. So when we start drug, we have to warn the patients about the intense conjunctival hyperemia that they are going to experience. So coming to Netarsudil, Netarsudil is another ROCK inhibitor. So it basically improves the trabecular outflow. So this is coming as a Netarsudil mesylate molecule, 0.02%. So we give it only at nighttime. So this not only causes ROCK inhibition, but also causes norepinephrine transport inhibition. So this came into view, a work from 2017, again in Japan. So the ROCK inhibition by this molecule is 20 times better than the other ROCK inhibitors. We also have another ROCK inhibitor called Fasudil, but it is not into clinical use now. So as discussed, it improves the trabecular outflow, but because of the NET inhibition, it also causes reduction in the aqueous production, also reduces the episcleral venous pressure. So this is really important to understand. This is one drug which really decreases the episcleral venous pressure. We don't have any other drug which actually improves or reduces the episcleral venous pressure. So by reduction of the trabecular outflow resistance in the distal portion, as well as reduction of the aqueous production from the proximal portion, this gives very good IOP reduction as per the trial results. So this causes both the trabecular meshwork as well as the episcleral vessel dilation. So only to understand the effect of Netarsudil, so you can see the Netarsudil treated trabecular meshwork, you can see the increase in space of the Schlemm's canal. So you can see increased space, increased force of the Schlemm's canal trabecular meshwork complex. So unlike Ripasudil, it also has reduction in aqueous production as well as the NET inhibition. So that gives a small edge of Netarsudil over the Ripasudil. So not going to the details of the study, only to know the side effects. So most common adverse event with the use of AR 13324 is Netarsudil again. So this was compared with Latanoprostene, and main side effect was ocular hyperemia. So this was found in 50% of the patients. It was found to be usually transient, and the severity decreased with repeated usage. So again, why this happens, we discussed before. So this is because of the vasodilator effect of the ROCK inhibitors. So this is one patient of ours who can see the intense vasodilation, and these are the small microhemorrhages. So this is classic of the ROCK inhibitors. So that is why we give at night so that the patient does not have so many symptoms during the day. So these drugs are not without side effects. This patient was actually posted for a combined phacotrabeculectomy. He came for some complaint, and when I lifted the lid, this is what I saw. So this is classic subconjunctival hemorrhage after Netarsudil. So we postponed the surgery. So we gave the patient some soft steroids, and the SAH gradually resolved. So it is really important that we understand these side effects of ROCK inhibitors before planning surgery. This is another side effect of ROCK inhibitors, cornea verticillata. So the reported incidence is around 26%. So this basically happens because of the accumulation of phospholipids in the lysozymes of corneal epithelium. You can see this classic vortex presentation. This is usually not vision threatening. It is only a mild side effect. It usually resolves with cessation of the drug. So we'll not go into the studies, but since these are all new drugs, it is better to know what name, what trial each drug has. So Rocket is for the Netarsudil and the ROCK inhibitors. We have different trials, 1, 2, 3, and 4, each for the efficacy and as well as for the safety. So this is basically to show that Netarsudil is not inferior to timolol. So any drug that we're going to start, we have to show it is not inferior to timolol. So coming to the side effects again, so 54% of the patients had conjunctival hyperemia. So cornea verticillata was also there and conjunctival hemorrhage. So these are side effects that we cannot ignore. So again, Netarsudil is not the magic drug. So this is again another patient with honeycomb reticular edema. So we will have side effects which you should be aware of. So how does it happen is something which we don't really understand. So as of now, when we stop the drug, it is usually reversible. So the mechanism, as I said, it is not yet clearly understood. So one proposed hypothesis is if there is endothelial decompensation, the risk of the honeycombing increases. So this is one patient with PKP where we started Netarsudil and the patient returned with a reticular edema and we had to stop, and the patient graft eventually recovered. So the time frame is also not clear. So when the patient develops conjunctival hyperemia, when he develops reticular edema is something which we don't understand yet. So coming to fixed drug combinations. So this is because of the new combination of Netarsudil with Latanoprostene that we're going to have. So fixed drugs combinations are always, they have a slight advantage because the dosing is better. So it is easy for the patient to apply the drop once. So because two medications are in one bottle, we have less exposure to preservatives. Cost reduction is something which when we go into the generic versus branded debate that can happen. But one few side effects of these fixed drug combinations is the fixed drug combination is not exactly additive. So 1 + 1 is not always equal to 2 because it's not only the active drug, but also the components, other excipients, all those things that also affect the bioavailability of the drug. In addition to that, we can have combined side effects of the both agents. So this is the fixed drug combination that is it's not available yet in India. So this is the combination of Netarsudil 0.02% plus Latanoprostene 0.05%. So again, it is given at night. Basically increases the trabecular meshwork as well as the uveoscleral flow and also decreases the aqueous humor inflow. So again, the studies for the new drug is Mercury 1 and 2. So and they found this fixed drug combination achieve better IOP control than individual Netarsudil or individual Latanoprostene. Again, the important side effect was more than 50% of the patients in this study had conjunctival hyperemia. So with this, we come to the end of ROCK inhibitors. So there are some unanswered questions in the ROCK. So when we start these ROCK inhibitors, we don't know yet whether these can be given as first line or add-on drugs. So because of the side effects of corneal edema, conjunctival hyperemia, so as of now, our stand is these will be given only as add-on drugs and not as first-line drugs. Again, efficacy in angle closure glaucoma. These drugs are initially approved only for open angle glaucomas and ocular hypertension. As we discussed, these improve the trabecular meshwork outflow, decreases the trabecular meshwork resistance. So in an angle closure patient, we are not sure how well this drug will act. Sometimes in desperate situations, we still give. Sometimes we say IOP reduction, sometimes we don't. But the efficacy in angle closure glaucoma, neovascular glaucoma, uveitic glaucoma, something which we don't really understand. Since these drugs are new, we don't know their safety in children, pregnancy, and lactation. So less than 18 years, be cautious. Again, there are a lot of new studies which discuss the antifibrotic effects and neuroprotection effect of these ROCK inhibitors. And these are even given as adjuncts to blood needling Again, these are unexplored areas. We need more post-marketing surveillance for these drugs to understand their side effects better. So this brings us to the end of ROCK inhibitors. We'll now go to the next drug, that is the latanoprostene bunod. So this comes in a concentration of 0.024%. So this is given at night. So as the name suggests, this is latanoprost plus bunod. So basically, this is a prostaglandin plus a nitric oxide donating antagonist. So as we all know, latanoprost increases the uveoscleral outflow, plus this molecule of butanoidol mononitrate donates nitric oxide. So nitric oxide, as we all know, causes vasodilatation, smooth muscle relaxation. So because of that, the trabecular meshwork outflow resistance is reduced. So we have one drug, we have one molecule which has two drugs, which increases the uveoscleral outflow as well as decreases the trabecular meshwork resistance. As with all these drugs, conjunctival hyperemia is a big side effect, eyelash growth because of the inclusion of latanoprost. So these side effects are expected. Again, only to know, so these are the trials that reported the efficacy of latanoprostene bunod. We have Voyager, Constellation, Apollo, Lunar, and Jupiter. There are so many trials for latanoprostene bunod. Again, as discussed, this is a new drug and we don't know their efficacy, their safety in pregnancy and lactation. It is better to avoid in patients who are less than 18 years of age. So coming to the next drug. So this is an interesting drug. So we'll discuss more about this drug. So this is not yet available in India. So this is Omidenepag isopropyl. So this comes as a 0.02% concentration. It's called OMD. So this is a non-prostaglandin prostanol EP2 receptor agonist. So again, this is highly selective. We'll come to the discussion of why this EP2 receptor selection is more important. So this increases the uveoscleral as well as the trabecular meshwork outflow. Again, all these drugs are approved first in Japan. So this was approved for use in glaucoma and ocular hypertension in 2018. Again, the main side effect is conjunctival hyperemia. Interestingly, this also causes an increase in the central corneal thickness. This is something which is very odd, which we have not seen in many of the other drugs. Again, these are the studies which compare the efficacy of, reported the efficacy of the OMD, IAME, RENGI, and the FUJI study. So this is one specific contraindication. So this is not indicated for use in aphakic and pseudophakic. So this is indicated only in phakic patients because the risk of CME is really, really high. So we don't want this drug in a patient who has a compromised capsule. Again, we cannot combine this with a prostaglandin. If you combine an EP2 receptor agonist with a prostaglandin, which is an FP2 receptor agonist, the side effects, inflammation, CME, all the complications increases. Now we'll come into the discussion of FP2 versus EP2 receptor activity. So this is one patient of ours, is a young patient, 40 years, but by the look of it, he does not look like 40 years. So this is because of the periorbital fat atrophy. So we all know prostaglandin drugs are the best, but this is the side effect of prostaglandin. He was on Bimatoprost. This is prostaglandin associated periorbitopathy. So these are these classic signs. You have upper litosis. So this is what we call as DUCE, deepening of the upper eyelid sulcus. This basically happens because of the destruction of the periorbital adipocytes. Why this happens? It's because whenever we give a prostaglandin, it acts on the FP2 receptor. So when we have FP2 receptor agonism, because of the action on the preorbital pre-adipocytes, so we have adipocyte differentiation inhibition. So then all these side effects happen. So we also have side effects of all these hypertrichosis and all those things. So all these side effects of prostaglandin, which we don't want, happens because of the FP2 receptor agonism. So when we discuss OMD, it does not have any FP2 receptor action. It has only EP2 receptor action. So OMD, with all the good effects of prostaglandin, does not have these cosmetic side effects of prostaglandin. So, but we don't have it available yet in India. But if we have access, this is going to be a really good drug with the effects of prostaglandin, but without the side effects. But one caution, we cannot use it in aphakic and pseudophakic, and we cannot combine with the prostaglandin analog. So coming to the next drug. So this is not exactly a topical drug. So this is an intracameral Bimatoprost implant. So as you can see here, this is from Malagan. So this is an implant. So this is a 10 microgram implant, biodegradable. So this once injected into the anterior chamber using a special delivery system is biodegradable for over 90 days. So this is the trial that reported the efficacy of Bimatoprost implant. This did not have any PAP. Since it was given intracameral, the side effects of the prostaglandin, eyelash growth, hyperpigmentation, all these things were not there, but it had an important side effect of corneal endothelial cell loss. So this can be given only once. So the initial trial gave 3 times at 16-week interval, but you cannot give it repeatedly. You can give only once, but you have to look at the endothelial cell count. If there is a drop, you have to actively monitor the specular count of the patient. So I'm not going into all these newer drugs. These are the several new drugs that are available. Adenosine receptor agonist, trabadazone, siRNA, cannabinoids. So we have travoprost, punctum plugs, Bimatoprost, Ocular ring, and we have travoprost iDose implant. So this is like iStent that is just injected into the anterior chamber of the trabecular meshwork. It just delivers the drug slowly. Some new things are in subconjunctival injection of dorsalamide. So we have a lot of activity going on with the nanospheres and nanosponges. So these are there only in animal studies. So this is only to know, but the clinical effects of these are not really understood. It is important that we reorient after reading about all the new drugs. So why do we want to start a patient on anti-glaucoma medication? So because IOP is the only modifiable risk factor in glaucoma. So we want a target at which further damage or progression does not happen. So we want the patient to have his existing vision without affecting his quality of life. This is what we have to understand. You can't pump a patient with all medications to have a 10 or 12 IOP at the cost of his quality of life. So that is what we have to understand when we're going to know about the new drugs. So target pressure is not static. It is weighing between patients and within the patient during the clinical course. Sometimes when he's progressing, we want more reduction in the IOP. So whenever we start a new drug, it is always better to have a 20 to 30% reduction and then titrate it down. For early glaucomas, it is okay to have at least 18 IOP and moderate 15 and advanced to have 12. So all these things keeping in mind without affecting the quality of life of the patient. So how do we set a target? So this is depending on the severity of glaucoma. What is the baseline untreated IOP that the patient has? What is the current rate of progression? What is the status of the fellow eye? And the family history and other risk factors like pseudo exfoliation and all those things, whether the patient is on concurrent steroids. So this graph is really important to understand. So when we have a young patient, the life expectancy is more. So this is the level of functional impairment. So we want our patient to have slow progression, have some vision, and not fall into this visual disability category before he dies. So that is our main goal, to arrest the rate of progression, to maintain the patient's glaucoma at a level so that he does not go blind before his death. So these medications are not without side effects. Ocular surface disease is real. So these are the concretions. You can see this is these are the PEs, punctate epithelial erosions, that are better appreciated when you put a cobalt blue filter and stain with fluorescent. And this is one extremely severe dry eye that we had after multiple glaucoma medications use. So this is real, and we should be cognizant of this side effect and not start the patient on glaucoma medications unnecessarily. So this was one patient who was on maximum medications. So we could not stabilize his ocular surface at all. He was uncontrolled on all AGMs. We started steroids for some time before surgery. But this is the picture after surgery, after the combined phaco trabeculectomy, and the trabeculectomy failed. So you can see the congestion still remaining. So it is important that we understand what we are starting, and it is important to optimize the conjunctival surface before planning trabeculectomy. So adherence is one issue that we have to really understand when we are starting glaucoma medications. So this study actually gave patients free Travatan, and they had a dosing aid, and they had someone who monitored their medication use. Still, only 45% of the patients took fewer than 75% of the prescribed dose. Adherence is a big issue that we face in glaucoma. So when we start a new drug, we should really understand what is the side effect and what is the efficacy, and not start the drug without understanding the mechanism. So this was one patient who had progression. So when I asked him to demonstrate how he was using his drop, I was surprised to see this. He had a mirror in his pocket, and this is how he was using. So it is important that we teach our patients how to apply drops. So glaucoma is a chronic disease, and we should make the patients understand that adherence is really important, because most of these patients are asymptomatic and will be starting medications and they will have symptoms and they stop using medications. So we have to make the patients understand about the nature of glaucoma medications and the nature of glaucoma before starting the medications. And it is critical that we explain the side effects also. So especially now that we have started ROCK inhibitors, I always tell them the effect of conjunctival hyperemia so that they don't come back without using the drop. So we have kept it simple. If postgraduates want to know more about the newer advances in medical management, this is one paper from our center. So this was on the newer advances in medical management. So this is published in IGO. So you can look at the latest trials that are available and latest trials results if you want and if you're interested to know about that. Thank you. We'll now open for discussion.
Thank you, Dr. Prasanna, for so well covering the whole gamut of newer medications. So I think now all the other glaucomas experts will help us in understanding something better or add to it. We can start with Dr. Maitri, the senior most glaucoma surgeon amongst us.
Yeah, thank you. It was a very nicely covered thing. 2 to 3 things, practical points, what I like to add. One thing is for the PGTs, they should know how to start the medications, that the follow-up chart, which is very important, how to start with them. And Dr. Prasanna has given that EGS guideline pictures that depends upon so many things. So you have to take a detailed history of the patient, what is its medical problem and all. And nowadays, our first line of therapy is always prostaglandin analog. And that depends upon, before starting that, what we need to know from the patient is economic conditions and all. It's not always necessary to start only the branded medications. There are a lot of other generics, also good generics. You can start with that. Like that, if the prostaglandin analog with one medication, your target RP is reached and patient is happy with that, follow them up with one medication only. And if you feel like the patient is not reaching the target IOP, then you can add one medication to see the effect of the second medications. If it is giving value and you are able to reach that, then there is a question of combining this two and a combo medications and follow them up. And the most important thing is regular visual field examinations to see the rate of progression. It's not like that you can stop the rate of progression. There won't be any progression, but there will be a progression. But is it in the acceptable range? So if it is acceptable range, continue that. There is no point of adding one or more than 2 to 3 medications because there will be side effects and there will be compliance issue. The newer drugs actually are coming up. We also need some experience for a long time. There are a lot of side effects will all are being demonstrated in the slides. That should be told to the patient. Dr. Prasanna also told that you should declare the things what the patient is going to face. Otherwise, they will be very anxious and they will call you up. One thing is that glaucoma, you have explained nicely. After that, they are having that thing in their mind. And second, that the side effect of the medications. But if you explain nicely that what is the gravity of the situation, the patient will not actually bother you for the side effects. They will ask you, what is the status of my eyes? Like, what is the intraocular pressure? How do you feel about it? So if they understands the gravity, they will not bother you too much with the mild kind of side effects. So that is the thing I thought like. And one point I like to add, that is the ROCK inhibitors when combined with beta blockers, the side effects are much less. So when ROCK inhibitors combined with beta blockers and given at night, so the side effects, what is been expected, will not be there in the morning that way. So if you feel like the side effects is bothering, but still you need ROCK inhibitors, you combined with beta blockers if the patient is not having any other systemic side effects for the beta blockers. That's the thing. I think anything else if you like to know?
Can I ask one as a non-glaucoma person? What is
Yes.
acceptable level of progression with the word which you uttered? Frankly speaking, to me, it's a new. You can also explain it for the sake of postgraduates.
That's a very intelligent question, but simultaneously is very difficult to answer. That needs experience and the progression. Before you see the rate of progression, and you need to get the GPA done. For me, I have that Humphrey. So you have to see that how it is. And that depends upon the the severity of the glaucoma. If it is a very severe glaucoma, then rate of progression, even if it is mild also, you should be alert. And there is no point of keep on adding the medications. Better to take the patients for the surgery, and that is going to help. It's very difficult, Dr. Bhavan Pule, that rate of progression, how much you are going to accept, that depends upon severity of the glaucoma and serial visual field you can make out.
Yes, yes, Dr. Bhavukla, I think ma'am has rightly said. And secondly, with the newer Humphrey machines that we have, it also gives you a value. So normally when we get this GP analysis, they will show you a rate. So if that rate is less than 1 decibel per year, is usually within the acceptable limit. It's basically aging also that encounters. And if anything which is more than 1 decibel per year, that one should be very wary of, and you should also tell the patient that this seems to be more than normal and we would like to see you regularly.
Absolutely, absolutely. Correct.
So I think understanding glaucoma progression using the trend-based and the event-based analysis is extremely important. And figuring out what is the age of the patient, what is the age expectancy of the patient, how severe is the glaucoma, all those things come into consideration when we are looking at what is acceptable and what is non-acceptable. And every individual has a different, you cannot generalize, okay, this level of progression rate is acceptable for for the population. No, every individual has a rate of progression which will differ depending on the disease at that point of time, depending on what is going on as far as his pressures are concerned. If any glaucoma surgery is being done, our baselines change accordingly. So automatically the rate of progression changes. If glaucoma surgery is done, then again the baseline changes. So it's a very dynamic sort of picture at that point of time regarding rate of progression for a patient.
Okay.
Another one important point is that rate of progression for a particular patient, what Dr. Maya has said just now, it changes, sometimes the rate of progression is quite stable. That is the importance of regular follow-up and doing the regular visual field test done. So that changes. Sometimes it's absolutely stable, and with the same medication, the rate of progression again changes. After the surgery, it changes. So rate of progression is very important thing to understand for a patient from time to time.
Dr. Prasanna, can I ask one of the questions which I have got from a postgraduate?
Sure,
How
sir.
do we can we have it in a step ladder pattern, the way we should move ahead with the medication from basics to the latest? I hope it is understood. I think he wants the way how it should move from basics to when should we start what exactly. That's what he meant probably.
I'll share a slide shortly, sir.
So I will just meanwhile I'll just add to what has been discussed. So what is important, especially in the peripheral colleges, that I think we reiterate in our also places, that the dosing that we write for the patients, many a times we just scribble OD, BD, HS. So the patients, they don't understand how much to put. So here we, especially in our clinics, we reiterate our students to put like if it's OD, we put a single circle. If it's TDS, we put like 3 circles. So at least, they know that it is 3 times. So for patients, it's very helpful that, grossly they understand, yeah, this one is HS, once that, we just put it at night, and this one is 3 times. And secondly, in medication dosing, apart from this, we also encourage as far as possible to start with monotherapy, because if you start multiple polytherapy that you say, you actually don't know which drug is acting when. So ideally you should start monotherapy depending on how much you want to reduce the IOP, and then stepwise you can add the second drug, third drug, and the fourth drug if required. And also because all the medications have a lot of side effects and the patients are just putting like this, so it is also important to demonstrate how to put an eye drop in front of the patient, and how to not to put on the skin, which happens when the patient is putting, he puts 3-4, if you look at the patient when they put 3-4 drops, and usually it falls in the skin and one into the eye. So that has to be avoided, because the prostaglandins have a lot of, or vital side effects because of this. And especially the carbonic anhydrase inhibitors also, they have this metallic taste. So we ask the patients to punctal occlusion. So the punctal occlusion has added benefit of, reducing the side effects, so that it doesn't go into the punctum, and also it gets absorbed into the ocular circulation.
I think ma'am has put a very important point in this, that any patient of at least who comes to me, if I've started a particular drug and if the drug has not acted according to what I expect, or if the patient is progressing despite, adequate IOP control or using drops, demonstration of the patient of how he's putting the drops in front of me is extremely important. Whether you ask the patient whether he's putting the drop while sitting or while lying, then you create that position, give the patient a bottle of Paracane, ask the attender also to have a look, and almost in 70 to 80% of cases, either the drop goes out, goes here, though it's not going inside the eye. And that is very important for us again to explain to the patient and the attender that it's not that the drop which is not acting, the drop is not going in properly for it to act properly. So then we sort of encourage the caregivers to start putting the drops and have a more important role in the glaucoma drops of this patient. So that's a very important point of actually checking how the patient is putting the drops.
To answer that question, can I share a few slides or?
Sure.
Fine.
We are there to answer them first.
So this is from another presentation. So this is the algorithm that I follow. So when we start a medication and the IOP does not drop, so if there is no response, so it is always better to check compliance first, as that was discussed before. So we have to also give adequate time for the drug to act first. So it's not good to start a drug and call the patient after 3 or 5 days and label it as no response. So on top of all this, it is important that we rule out angle closure and not miss secondary clauses like PXF, steroids, trauma, and all those things. It is also better to check IUP with the same instrument GAT preferably, and check for smaller issues like instrument calibration. In selected cases, you can also do DVT. So if there is no response, as discussed, it is better to switch before adding an AGL. So intra-class switch is what we do for prostaglandins. If latanoprost is not working, you can switch to a travoprost. So this is not necessary with others like timolol or carbonic anhydrase inhibitors. So if we don't see a response, that is, if the IOP does not reduce by at least 20 to 30%, then we call it no response. If there is response, but it is inadequate, now we can add an AGM. So it is better to give friendly combinations. As I had discussed before, it is important that we understand the patient's quality of life. We can't give 4 medications, putting 3 times, 2 times daily. They also have to lead their life. It is not possible. So it is always better to combine drugs with different mechanism of actions. So prostaglandin, which enhances outflow, and beta blockers, which decreases inflow. So this is the best combination that you can give for the patient. So this is the algorithm that I follow. These algorithms are also available in the EGS guidelines. So I usually start prostaglandin. If it's not possible, if cost is an issue, you can start timolol. Monotherapy again. So this is possible in a primary disease. We can't use this algorithm for a secondary glaucoma, neovascular glaucoma. So you can review the patient in 2 to 3 weeks. So in the meantime, if you are afraid of the IOP spikes, you can always give Diamox cover. If the response is good, continue. You can plan investigations HFA OCT based on the stage of glaucoma. If the response is there, but it is not adequate, now I would add alpha agonists. Why alpha agonists over carbonic anhydrase inhibitors is CAIs only decrease aqueous production. But alpha agonists, though they have little bit more side effects, also have some uveoscleral outflow enhancing potential. So I would add that. So than CAIs. If there is no response, it is better to switch. If it's a prostaglandin, if I have started latanoprost, that is my first choice always. You can always switch to travoprost or bimatoprost. So further switching all these addition, it is all based on the cost issues and the side effects. Again, as I had said before, secondary glaucomas, all these things don't work. You have to start the patient on maximal medical therapy. But one caveat is you will not know which drug is not acting. But in secondary glaucomas, we have no other option but to go with this. And we will also not know which side effect the patient is experiencing because of which drug. But we have to just go with the experience.
There is one more question. Sir, can you elaborate on those newer drugs which you have mentioned, like sRNA and all those things? Anyone of you can answer, brother? Anyone? Dr. Angmo, Dr. Devang or Moyav, anyone, or even Dr. Prasanna, can you elaborate for them?
I have not gone into the details because it was too theoretical. So
That's what.
those are all only in animal studies. If someone is interested, they can always go through that paper from IGO. So every discussion is given in that siRNAs. We have
I
newer
think
drugs
you
and all
can,
those
in
things.
short, tell them the mechanisms, how they are working, their proposed mechanisms, I believe, for their understanding, I think.
Yeah, these mainly, there are many things which mainly act on the trabecular meshwork. So though we tell these drugs increase the trabecular meshwork outflow, the efficacy is proven only in the animal models. So it is not translated into the clinical trials yet. So some drugs are known to increase optic nerve head blood flow. But how much, we all know the role of neuroprotection in glaucoma. It is slightly controversial. So though we say some drug increases ONH blood flow, it does not really translate into prevention of glaucoma progression. So these are all just in the clinical trials. It is good if you know the names. That is what I would, because these things with time, these things can go out of vogue. So
Dr. Devang,
That's
can
true,
you add to it?
Prasanna. Yeah, that's true, Prasanna, because all these, whatever molecules that we are studying, so if you study 10 molecules, actually, if you look into human eyes, two would be, crossing all the phase 1, 2, 3 trials, and then actually, comes into the market. So it's like as at PG level, especially for PG MCQ exams and all, it's good to know. But beyond that, it's just like theory.
Netarsudil, Latanoprostene, bunod, the combination of Latanoprost and Netarsudil and probably Omidenepag are the only drugs, I think, as of now, which require us to, give some sort of thinking behind it. And out of them, even Latanoprostene bunod is not available in India as yet. So, we may not have many options, even in the ones which are quite well studied in studies abroad.
Here's one more question. Sir, that implant which you have spoken about,
Durista.
will it be removed?
Durista.
Is what they have
no,
asked.
it is biodegradable.
Usually.
It stays in the anti-aging.
So you keep on injecting every 3 monthly?
That was the
That's for me.
original trial. That was the original trial, but they had a lot of side effects. But now the current understanding is to inject only once and not beyond that.
So when do we inject? This is from me, this question for my understanding.
Again, there is a concern about the corneal endothelial cell loss. So if you have a glaucoma patient who has, but if you are planning to inject, the patient has side effects, better to do a specular microscopy, document good specular, and then go ahead. So again, in open angle glaucomas or ocular hypertensives, who are not able to, whom we can't plan surgery because of some issues, who are not willing, who have systemic side effects and all those things.
Just for my better understanding, that implant is as we know, the disease is a chronic disease, it's a lifelong commitment. So at what stage and in which cases would you use it only for the sake of 3 months and then again go back to drug or go back to surgery? It means, which are those absolute indications for this?
I did not go into the details of the trial. So the Artemis trial, what they had told was, so in majority around 40%, they did not require any further medications at all. So which is really good compared to the load that we have. So they had done in open angle glaucomas and ocular hypertensives. So early glaucomas, not advanced. So right now, we don't have any clear understanding of this because it is not available and we don't know the side effects yet. But it is only in the trial. It was approved in US, but we don't have it yet here.
So 40% got cured by that disease?
Did not require additional thing, not cured. So again, we'll know these side effects only with
early
time.
disease, no?
Only with time. So again, this patient can develop glaucoma with time. So we need longer follow-ups. Again, as with all these drugs, we need post-marketing surveillance. Only with time, we'll have better answers with all these implants, be topical or these injectable ones.
So Dr. Bavankle, the answer actually is that Prasanna told that the patient selection has been very early, like ocular hypertensions. So they're at the, they're at the initial stage. So if you give them the drug, maybe, you know, there's some sort of receptor or something which happens, and they probably did not require the medication for 1 year. So, but still we don't have data for 5 years or 10 years. How do you know that the disease did not progress? So all these are still, you know, getting studied. So we cannot comment upon as of now.
Aim basically is to prolong the starting of the drug, of the topical drug, to prevent the potential side effects which can happen, and reduce. So obviously there's no chance, there's no question of adherence and compliance in these patients. So you're sure that the drug is inside the anterior chamber, it's eluting at a particular rate, it's having a particular action on the IOP, and that is it. So patients means obviously it was taken into account quality of life of a patient and the fact that compliance and adherence are such big issues. So what else can we do to answer those issues? And this implant was one of them. But as Dr. Prasanna said, there was quite a significant reduction of corneal endothelial cell loss. So we've had other implants which have been completely withdrawn of the market, like the CyPass, which was a suprachoroidal implant which was there. And this is something similar. If you're going to have corneal endothelial cell loss, then no efficacy is worth that sort of side effect.
Okay.
Also, so in the beginning, I mean, whatever I remember about the study was that after, whenever these implants, get implanted, actually theoretically it is thought that, this particular concentration will be released for this particular weeks. But it has been studied in animal eyes that when the drug implant was put, there was a maximum concentration of that initially. And with time, the concentration reduces, and therefore the efficacy also reduces. So that is also one of a very big thing which needs to be studied, because if at the beginning a lot of drug is released, so obviously the side effect profile will be more, and later on when the concentration decreases, the actually efficacy also decreases.
Multiple
us as a
injections, the efficacy reduced
vitreoretinal
even further.
For us as a vitreoretinal surgeon, all the polymers or whatever those carriers are which we use in vitreoretinal things, implants, or call it ozodrex, or they usually are believed to emit at a particular rate only. They do not, their outflow or giving of the drug is not decreased over a period of time. That fixed dosing is given. So probably the polymer which harnesses it must be studied. It is the drug which must be, I don't know how it
Also,
is different.
not only the polymer, but also the vitreous is like a gel thing. So obviously there's no, it's rigid. There's no osmosis, or there's no, transfusion. But aqueous is, as you all know, that there are active aqueous currents. That is, and it's more vigorous than what vitreous is. So that
Okay.
is also one of the reasons.
Okay, fine. So any more questions any more discussion?
One thing that I would ask, just the house and also to Dr. Prasanna, that in ROCK inhibitors, when patients are using, we have seen that they, although there is hyperemia to start with, but it improves over time. So, how many percentage of you guys have seen that, and how do you deal with hyperemia if the patient comes?
So we warned them before starting, but the issue is we have not started these ROCK inhibitors as the primary drug in naive eyes. So when the patient is already on a lot of AGM, so this just adds to the hyperemia. So with time, they say it improves, but the patient always has red eyes. So the patient with hyperemia, we don't really stop unless the patient has like frank subconjunctival hemorrhage. The patient develops reticular edema, we stop the drug. And most of the patients understand when we tell them reticular edema. When the honeycombing
patient with lid edema, you stop.
Reticular edema, the honeycombing, madam.
Okay, reticular edema.
When there is reticular edema, we stop the drug. So there is no going back. So when there is hyperemia, we tell them if they can tolerate, we push for some time. But the issue is with this hyperemic guys, if you're planning surgery, are you willing to take the risk of failure of surgery? So that is something which we don't really understand. So we as of now, it's not our first line of drug. It's only an add-on when we can't do surgery for some reasons.
It's in our practice here, it's more of a third line or fourth line drug. If we want to plan, we know surgery is going to happen in some time, but we just want to delay it for some reason. Patient can't undergo surgery for some reason, and we want that extra IOP drop for a few more months at that point of time. Or if he is having side effects to other medications, and we're trying it out on this whether Netarsudil or Ripasudil actually works or not. But one place where I don't give any of these drugs in is in post DSEC or post PKIs, because 3 or 4 patients I have seen in a week of starting the drug having the honeycomb or radicular appearance. So this particular subgroup of patients, I do not give it at all. And endothelial patients with endothelial cell loss or some sort of decompensated cornea, the cornea colleagues are using it as a way of treating that. And if in those patients it would cause reticular edema, it was something which I was not able to understand that mechanism of action very well as to why should it happen in those patients whose endothelium is compromised when it is being used by cornea colleagues for patients who have post-op corneal edema or something of that sort. But
we have seen that too. So in this developing in patients post endothelial keratoplasties and PKPs. Again, when that happens, we stop. But those patients are all having refractory glaucoma. So the next step is either diode or tube. So that bridging is really difficult.
This Ripasudil actually works very good in uveitic glaucoma. So out of all the glaucomas, the secondary glaucoma, especially the uveitic glaucoma, so you can try and see a lot of patients actually respond well compared to the primary open-angle glaucomas. And for the hyperemia, it actually goes off within, not exactly goes off, but it reduces after 2 to 3 weeks. So if the patient can tolerate the drug well, this actually dampens. And if it combines, when combined with beta blocker, the hyperemia, actually, I think it's because of the vasoconstriction. So that's why the hyperemia reduces. So you can combine it with beta blocker and try it, especially at night.
Again, this depends if the patient has 1A glaucoma or both A glaucoma. So if it's unilateral and you're going to start Netarsudil in 1A, it becomes more pronounced. So if it is a bilateral, they usually kind of accept.
Yes.
So like Dr. Prasanna had told that initially we were also using it for third line or second line. We never used it when it was launched by 28. By the time it came to India, it was like post-COVID when it was actually available. So we had seen that patients, I mean, I was pretty surprised in few patients who were on maximal medical therapy referred to us, and we had no option, and we added these ROCK inhibitors. Few of these patients have actually given a very good response to this ROCK inhibitor. So that is one thing. I mean, because all these were secondary glaucomas, we didn't want to, do primary surgery per se. So those few patients had responded very well in when they were given as second or third line ROCK inhibitors. And in terms of redness, because obviously the patient is already on so many drugs and you give a ROCK inhibitor, I've seen that, there is some amount of congestion is always there because you've added this third or fourth drug. But recently we've done this thesis, we've done an RCT as a monotherapy of Netarsudil versus dorzolamide to see the effect on the optic nerve head blood flow as well. And because it was given in naive eyes, we were pleasantly surprised that the congestion was there in nearly 50% of the patients, but these congestion reduced over time. When they came for the second follow-up, maybe after 6 weeks, 3 months, and we counseled them that, you need to put this drug, and by the time they came to us in the second follow-up, the congestion had markedly reduced and the patient was actually putting the drugs. They had no problem in putting the drugs thereafter. So in monotherapy, I've seen that the side effect profile is definitely lower, and especially with the single dosing. If I give Ripasudil BD dosing, the congestion and things are very on the higher side. So I usually give it at the night, as Dr. Prasanna told, just before sleeping you put. By the time they wake up, the congestion and everything goes off.
I have a question, ma'am. How is your experience in angle closure glaucomas? Because the role of these ROCK inhibitors in angle closure is something controversial. So do you give an angle closure eyes?
Not as, I would never give it as like a primary, therapy. Again, I would give it as like a third line or a fourth line, something like that. but it's not my primary therapy. Again, as you've mentioned that always prostaglandin will be at top, then a beta blocker, and then I would think of, if it's not getting controlled, then alpha, alpha agonist, and then maybe a ROCK inhibitor.
Okay.
And in terms of corneal edema, what we have noted is that these reticular edemas is that in patients who are having high IOPs, and we are giving these ROCK inhibitors, those were the patients where we have noted a lot of reticular edema. And patients in which the pressures were not more than 30, it was less than 30, and we gave it like with other combination drugs, we've never seen reticular edema in any of these patients.
That I have seen in my patients that even in the low IOP, but not reaching the target, and the patient is progressing, and you have to add something or other. So pressure is actually low, somewhere around 18 to 24, something like that. They also develop this. So
what was the diagnosis of the patient? Like what profile was it?
I'm sorry?
What was the diagnosis of the patient, whether it was a primary glaucoma or a secondary glaucoma?
No, I'm talking about primary glaucomas. Primary glaucomas.
So you are muted.
Dr. Bavangule, you are muted.
Yeah, we had a fruitful discussion. Any more things from the sake of, from the point of view of postgraduates you would like to highlight?
I would also, just to add on to these drugs, that anti-glaucoma, especially with the weather and the medications also, these anti-glaucoma medications also, they add to the xerosis. So chronically they are being used, and that's why we need to be judiciously prescribing these medications, not to prescribe polytherapy in one go, and not to add lubricating drops just prophylactically.
Great. So I think we had a wonderful discussion, and we have almost reached 9 p.m. Almost 9 p.m. I think it's time for us to say goodbye. Thank you, Dr. Prasanna, for so well covering this difficult topic for the sake of postgraduates, and all the discussion, Dr. Maya, Dr. Devang, and Dr. Maitri, for making that topic more easier for the postgraduates to understand how to initiate the therapy, what are the mechanisms of action. Thank you, each one of you, for sparing this time for all our postgraduates from our country. So, postgraduates, it's time for us to say goodbye from our end. We'll be meeting again on the following weekend, again at 8 p.m. Okay? Then, till then, bye-bye from every one of us. Thank you, everyone. Thank you.
Good night.
Thank
Good
you.
night.
Thank you.
Thank you.
Thank you. Good night. Good night.
Bye.
Thank you, Dr. Bangule.
Thank you.
Thank you,
Thank you,
sir.
sir.
Bye.
Thank you, Maitri. Thank you.
Thank you, Prashant. Thank you.
Thank
Thank
you,
you,
Maitri.
Thank you.
everybody.
Thank you, everyone.